Okay. So welcome to your second lecture for your PICU boot camp. We'll talk about mechanical ventilation today. As I go through, if you guys have any questions, please feel free to interject or raise your hand. We'll figure out the best way to answer your questions. But I want to make sure you guys are getting just like the basics and just a good overview. So spontaneous versus mechanical ventilation. When we talk about this, we're talking about your natural breathing versus what's going on when you're on the ventilator. So during natural breathing, it's a negative inspiratory force. So air is being pulled into your lungs, as opposed to when you're on mechanical ventilation, which is a positive inspiratory pressure. So air is being pushed into the lungs. So this is just a quick schematic taking you back to probably first year medical school, looking at the intrapulmonary airways. And this will become important as we go through the lecture to know what we're talking about, the different parts of the lungs. So when we talk about ventilation, it's basically describing CO2 elimination. And this is going to be determined by your minute ventilation, which is your respiratory rate times your tidal volume. So efforts to reduce CO2 involve increasing your respiratory rate or increasing the tidal volume. Oxygenation is primarily determined by your mean airway pressure. This is the average pressure in the respiratory system over time, and this is also determined by your FiO2. So big question is, when do we want to initiate mechanical ventilation? When do you guys think are some good reasons to initiate mechanical ventilation? No wrong answers.
Yeah, you guys can type down in the chat or unmute yourselves, either one.
Nobody? Viewer? Okay.
Hypoxic respiratory failure.
Yes, that's a great one. First one, okay. Second one is hypercarbia, so really high CO2. Airway protection, so if you have someone that is found unconscious and they're not protecting their airway, that's another reason, or a trauma is why we would do mechanical ventilation. And then in order to decrease demand in cases of poor cardiac output, so a lot of the cardiac babies, the best thing for them will be to put them on mechanical ventilation. Okay. So some important terms that we're going to talk about, I know it seems like a lot, but this is just a brief overview. So we're going to talk about time, and you might hear the term tossed around, your I time and your E time. So just to break it down, your I time is going to be the amount of time that's spent in inspiration, and your E time is the amount of time spent in expiration. So a lot of times you'll hear when you guys come to the unit, what's your I to E ratio, and that's just to say what's your time you're being spent in inspiration and the time you're spent in expiration. Volume is going to be the amount of tidal volume that a patient receives. Pressure is going to be the measure of impedance to gas flow rate. And then your flow is going to be the measure of rate at which gas is delivered. So PEEP is the positive and expiratory pressure. It's the pressure maintained at the airways. Sorry. It's the pressure maintained in the airways at the end of exhalation, and that's what's going to keep your alveoli from collapsing. And then your peak inspiratory pressure is the point of maximal airway pressure. And then the delta P is going to be your difference between your PIP and your PEEP, and your mean airway pressure is your MAP. So there's a lot of terms. Just want to make you guys familiar with it. You don't have to commit those to memory right now. So different types of ventilation. So there's different modes of ventilation. The big four that we're going to talk about are your assist control, your synchronized intermittent mandatory ventilation, or SIMV, continuous positive airway pressure, and high frequency oscillating ventilation. We're not going to really talk about the oscillator, but I just wanted to put it in here as a mode. I'm sure you guys have seen that in the NICU at some point. So first mode that we're going to talk about is assist control. So it can be set at either volume or pressure. And the parameters that you will set on the ventilator are volume or pressure, your rate, your I time, and your FiO2. So during assist control, the machine breaths delivers the set volume or pressure. The patient's spontaneous breath is the ventilator delivers full set volume or pressure and I time. And it is the mode of ventilation that provides the most support. So this is a good mode. We use it a lot in the adults who have sicker lungs. And also if you want to take over complete control, like if your patient is fully paralyzed and not initiating any breath assist control, is a good mode of ventilation. SIMV, synchronized intermittent mandatory ventilation. This is the mode that is most often used in pediatrics. It could be set in either a volume or pressure mode. And the parameters that are set are volume or pressure, respiratory rate, I time, FiO2, and your pressure support. So for your machine breaths, it's going to deliver the set volume or pressure. When a patient takes a spontaneous breath, the set pressure support is delivered. And the mode of ventilation provides moderate amount of support. So it works well in a weaning mode. So this is from assist control, you're totally controlled, remember. So even as you wean, it's not letting the patient do anything on its own. So SIMV, the patient is doing a lot of it on their own. Any questions so far before I go forward? Anything? Okay. Okay, so volume ventilation, which could either be set in either assist control or SIMV, you're going to preset your volume, your PEEP, your rate, your I time, and your FiO2. The ventilator is going to determine the pressure required in order to get to those preset volumes. So some advantages of a volume ventilation, it's guaranteed minute ventilation. It's a more comfortable mode for your patients. However, there are some drawbacks. You can get a large leak around the ET tube, especially if you have an uncuffed tube. And it's not optimal for poorly compliant lungs. So if you have really sick ARDS lungs, it's not a good mode for them. And then pressure ventilation. So again, this is a mode that can be set in either assist control or SIMV. So you're going to preset your peak inspiratory pressure, your PEEP, your rate, your I time, and your FiO2. And then the vent determines the tidal volume that is given. So some advantages of pressure ventilation, it provides more support at a lower peak inspiratory pressure for poorly compliant lungs. However, the big drawback is going to be that your minute ventilation is not guaranteed. So just a quick chart going over what the advantages of each mode is. So again, like we talked about, assist control ventilation, you have a reduced work of breathing compared to spontaneous breathing. And then SIMV, there is less interference with normal cardiovascular function. And then some disadvantages of each mode. So in assist control ventilation, there's potential adverse hemodynamic effects, which may lead to inappropriate hyperventilation if you just have to pay more attention to when the lungs are becoming more compliant. And then in SIMV, you have increased work of breathing when you compare it to assist control. So if you see a patient that's really working hard to keep it synchronous with events, sometimes we'll switch them into assist control mode. And then I'm just going to quickly touch on pressure support or CPAP. So the parameters that you're going to set in this mode are pressure support and your FiO2. There are no machine breaths. And the set pressure is support is determined by how much your patient pulls on its own. And its purposes is usually the final steps prior to extubation, and it can be used to retrain muscle strength if you have a patient who has been intubated for a long period of time. Okay, so everything I said at this point is probably clear as mud, right, guys? So you're nodding or you've fallen asleep already. Stop me if you have questions. So I'm going to try and break it down a little bit easier for you guys. So two-step process. So step one, you're going to decide the amount of support the vent will give the patient, either assist control or SIMV. So remember, in assist control, it's more support and control. Every breath, whether mechanical or spontaneous, with this patient trigger, results in a fully supported breath. So in synchronized intermittent mandatory ventilation, SIMV, the ventilator delivers the set number of breaths with a preset peak inspiratory pressure or tidal volume. Any spontaneous patient trigger breath above this rate receive the set pressure support only. So sometimes this is a weaning mode, like I said before, and is used mostly in the PICU. Adults don't usually use this mode as much. And then step two, you want to decide which variable will be controlled or set. So either pressure control or PRVC. So in pressure control, you're going to set the pressures, your inspiratory pressure and your PEEP. The tidal volume becomes your dependent variable and thus depends on the patient's compliance and the airway resistance. So in the volume controller PRVC, you're setting the tidal volume and the ventilator delivers that volume. And so your pressures become the dependent variable and thus depends on the patient's compliance and airway resistance. So the more compliant your lung is, the less pressure required to achieve the set tidal volume. And then the advantage in this mode is that the minute ventilation is guaranteed. Okay, so two-step process just to make it really quick and simple. So managing the patient. So this is a lot charged, a lot of words, and I'll make sure you guys get it, but it just has what we think of as our initial modes. So you're going to, if you're going to set a pressure mode, your PIP, you need to get about 6 to 8 of tidal volumes in healthy lungs. PEEP is usually about a 5, and then your rate, physical logic for age is what we're going to do. So if you have a small infant, we usually start about 30, 20 for a toddler, about 12, usually maybe a little bit higher, 12 to 15 in adolescence. And then our FiO2, our goal is to try to get to 30%, and pressure support is usually about 10 in most patients. So a little bit about pulmonary compliance, because that's what we're going to be looking at once a patient is on the ventilator. So if you guys remember, compliance is equal to volume over your pressure. You monitor your patient's clinical changes. So as your compliance improves in a volume mode, your required pressure is going to decrease. And in a pressure mode, the generated volume increases. So hypoxia. So it really usually results as a result of hypoventilation. So you're going to get decreased alveolar ventilation, more of a CNS depression, diffuse impairment, abnormality at the pulmonary capillary bed, or shunt. So you're going to get blood flow without gas exchange. Shunts could be either intrapulmonary or intracardiac. And then last cause of hypoxia is usually a PICU mismatch, so both dead space and shunt abnormalities. So some adjustments. So if we want to adjust oxygenation on the ventilator, the big thing we're going to look at is your mean airway pressure. And these four things, your FiO2, your PEEP, your I time, and your PIP, are all going to influence your mean airway pressure. So those are all things that we look at if we're having a problem oxygenating the patient. If I want to adjust ventilation, we're going to look at your respiratory rate and your tidal volume. So some troubleshooting, you're going to run into a problem and say, have a bad gas. So first thing you want to do is examine your patient. Nothing ever replaces the clinical exam. So you look at the patient, you listen to judge for yourself how the patient is doing. Does the patient appear pink and well perfused? Has the respiratory rate of the patient decreased? Is the chest moving? Are breath sounds present? Then you're going to look at your pulse ox, maybe send an ABG, maybe check end-tidal CO2. These tests are more often than not to confirm your clinical impression. They certainly have a role when the clinical exam may be indeterminate, and they can be more sensitive in detecting small changes, but they're not going to replace your physical exam. You can get a chest x-ray that can be used to confirm that the tube is in good position. It can be used to follow the progression of the patient's disease. And chest x-rays are also helpful if there's acute changes, such as a pneumothorax or right upper lobe collapse. So those are the big things that you're going to be looking at. And then looking at the vent, of course, you want to look at your expired tidal volume. Has your peak pressures gone up? What is alarming on the vent? But again, first thing you want to do when troubleshooting is to examine your patient. Other things you could do if you're having a problem with the vent. This is not something that we will expect you guys to do, but something that you might see us or the respiratory therapist is disconnecting the patient from the ventilator. And to begin bag ventilation. You want to make sure you're bagging with 100% FiO2. And then this eliminates the vent circuit as a source of the problem. Hand bagging the patient sometimes can make us see if it's hard or easy to bag the patient and how the compliance is. But it's also a prime example in critical care medicine where you always want to make sure that your equipment is working. So when it comes to troubleshooting, we go through our ABCs. Airway is always first, making sure that the tube is in, making sure that you have end tidal, and breathing is next. We want to look at, is the chest rising? Are breath sounds present and equal? Is there changes in the exam? And then circulation, shock or sepsis, that can sometimes present as having issues with ventilation. So time for a question. Okay, I'll let you guys read and then give me an answer for this first one. Okay, what do you guys think the answer is? John, I'm not able to see any comments. Are they hearing me or able to answer?
Dr. Spence, everyone said A. It's in the chat section.
Okay, sorry, I didn't able to see the comments. So you guys said
A.
A. I'm sorry, I think I skipped ahead. Which? Okay, thanks. Yes, so definitely A. Um, Thanks, guys. I don't know why I am not. So your mean airway pressure is the primary determinant of oxygenation when on mechanical ventilation. So changes that result in increased mean airway pressure generally help to improve oxygenation. So you guys are exactly right. Okay, second question.
I just got back from my delivery. Looks like several answers for A.
I think that was for the first question, Jonna.
Okay,
Then you
sorry.
go get to the second one. Yeah.
Couple D.
Great. Yeah. D is the correct answer. So guaranteed tidal volumes occur with volume controlled ventilation or PRVC, not pressure control. Okay. And that's it, guys. Do you guys have any questions? Was that helpful? Okay, now I'm seeing the comments.
Yeah, the your RTs guys will like save your life in the middle of the night. So if you've thought through a couple of the troubleshooting things that Dr. Spence mentioned, ask your RT like in this situation, what would you do? And they're super helpful. And like Dr. Spence said, you can always revert to bagging and suctioning if you're really in a tight spot. So I've been emailing them to you guys just because they're huge files. Pion asked where I was going to be posting these. If you guys want me to post them somewhere on Sakai, I can find a place. I probably won't do it on the PICU website because they're just huge files. I'll have to find a way to link it. But I'll email this to you guys too.
Okay. Thanks, guys. Let me know if you have any questions. Okay. Thanks, Shauna.
Thanks, guys. Thanks, Dr. Spence.